Hi, this is Dr. Ballard. I'm going to be recording part 2 of the Clinical Decision-Making, Clinical Judgment lecture. So we stopped at the last time on what is a symptom. Remember the attributes of a symptom that we've gone over in class before. Remember your old carts: onset, location, duration, characteristics, associated signs and symptoms or aggravating factors, relieving factors, timing, and severity. Remember the key symptoms, the key attributes of a symptom. Thinking about timing and onset: when did it start, how long has it been going on, how often does it occur, how long does it last. Location: where is the pain or where is the symptom? Does it radiate? How bad is the symptom? Severity, quantity, duration on a scale of 1 to 10. How many times, how much, for how long? Quality: use descriptors such as burning, aching, sharp, dull, etc. Associated signs and symptoms. You also want to think of associated symptoms. What else accompanies it? Is there a pattern? Is it associated with certain activities, meals, etc.? Alleviating factors: what kinds of things have helped, either medicines or non-pharmacological treatments? What things aggravate? What makes it worse? Settings: where does it happen, including environmental factors, activities, circumstances, etc. Also think of severity. To make sure that you have quality data in terms of your history and your symptoms, make sure that you always ask open-ended questions. We've talked about this in the beginning when we went over the history and interviewing techniques. You'll get much more information if you ask an open-ended question than if you ask just yes/no questions. There are some times when you need to ask directed questions to get the information that you need, but if you're trying to gather broad information, ask open-ended questions. You want to develop a systematic and thorough method for history taking. Remember that 90% of your data comes from the history. So begin with your history of present illness. Begin with past medical history, then family history, social history. Always try to go in an organized and systematic way of doing the history taking so that you won't overlook things. Make sure that you keep an open mind to the patient and their information. And if you always include the worst case scenario, you'll make sure that you have safely eliminated it in your workup. You'll make sure that you ask the right questions to rule that out. It's important to confer with colleagues and the literature to clarify and help you determine your diagnosis, and apply the principles of data analysis to your information and the tests that you gather. A great majority of diagnosis can be achieved with the information from a competent history in your clinical examination. They work hand in hand. Basically, your clinical examination supports your history and confirms your suspicions. Limit the indiscriminate use of expensive technology. Keep in mind that technology and tests and diagnostic tests are to support your tentative diagnosis and to help confirm. If it's not going to change what you do, or you don't need it to support your diagnosis, then there's no point in doing expensive tests. Whenever you're trying to consider what tests you order, you'll want to keep in mind that clinical data, including laboratory tests, are imperfect In other words, make sure that you are treating the patient and not the tests, because you have to put it all together. Don't just rely on the laboratory tests or the diagnostic tests. They can improve your assessment of clinical data by selecting the appropriate tests. So you want to make sure that you use tests that are reliable, that are valid, and sensitive and specific to what you're trying to diagnose. Your confidence in the results aids in your decision making in the results of your tests. So when we think of reliability, we think of a test that indicates how well repeated measures of the same phenomena will give you the same results. We could also call this precision. In other words, how well the same test will give you the same results each time. Also consider validity of the test. This indicates how closely a given measurement or observation agrees with the best test or the best measurement of reality. So all tests have what we call a gold standard. So you want to look at the validity of that particular test. For example, blood pressure measurement by mercury sphygmomanometer is less accurate than intra-arterial measurements, which is the gold standard. Sensitivity. Remember, sensitivity is the proportion of people who test positive in a group of people known to have the disease. In other words, the true positives. When the results are negative in persons who truly have the disease, we call this false negatives. A good test has a sensitivity of more than 90% and helps to rule out a disease because there are few false negatives. Tests that are high in sensitivity are good for screening. For example, Hohmann's test for DVT is not a very sensitive test in that less than 50% sensitive. So, in other words, 50% who truly have a DVT will have a positive Hohmann sign, so it's not a good test to rule out DVTs. Also consider specificity. Specificity identifies those who test negative in a group of people known to be without a given disease. The proportion of people who are true negatives. When the results are positive in persons without the disease, we call this false positives. Good tests have a specificity of over 90% and help to rule in the disease since there are very few false positives. For example, serum amylase has a low specificity for ruling in pancreatitis because specificity is less than 70%. This means that 30% of the patients without pancreatitis will have a falsely elevated amylase. So we want to look at the validity of the information, including sensitivity, specificity, true positives, and true negatives. So sensitivity, the ability of an observation to identify correctly those who have a disease. The specificity, the ability of an observation to identify correctly those who do not have the disease. True positives, expected observation that is found when the disease characterized by that observation is present. And true negatives is the expected observation that is not found when the disease characterized by that observation is not present. False positives and false negatives, the observation made that suggests a disease when that disease is not present, and a false negative is the disease is present, the observation is there, but it is not appreciated. Positive predictive value is the proportion of persons with an observation characteristic of a disease who have it. and negative predictive value is the proportion of persons with an expected observation who ultimately prove not to have the expected condition. Bayes' theorem tells us that the likelihood of your diagnosis being related to your findings depends on both the probability of those findings being associated with that diagnosis and the prevalence of both that particular diagnosis and that combination of findings in the community in which you are serving. So once you've come up with your diagnosis, you're going to be developing your evaluation and management plans, and you're going to be setting priorities. You decide what you think is going on, that's your diagnosis, and what you're going to do about it, which is the management plan. Both you and the patient arrive at a jointly considered approach. In your evaluation and management, you're going to consider the laboratory and radiological studies, consultations requested, medications or appliances prescribed, special care to be provided, surgery, diet, activity modifications, follow-up schedule, and patient education needs. You also want to evaluate the patient's physical condition. Is there something going on that overrides every other consideration? Are there abnormal lab values or radiologic findings that need immediate attention? Also consider the patient's social circumstances. Will their job be threatened if they have prolonged absence from work? Are there small children at home who have no other caretaker available? Is there transportation to and from services and care, etc.? And what is the patient's economic circumstances? Do they have adequate insurance coverage? Is the cost of care going to compromise other areas of their life? The patient's subsequent behavior is a major variable in health prevention or therapeutic circumstance. For example, smoking cessation, whether or not they're going to be able to adhere to the medication regimen that you prescribe. The patient must be actively and positively involved if an optimal outcome is to be achieved. In other words, you can't just tell them what to do. You have to gain their trust, and both of you come up with a plan that is agreeable. We want to look at other things in the patient's life that will affect the outcome. Does the patient want to take the necessary steps? What is the extent of the patient's commitment and recognition that the benefits of action outweigh any possible disadvantages? And what is their ability to sustain the effort? Make sure that you pay careful attention to recording the information using the findings in the history and physical exam, which will lead to the discipline by which you can organize your thoughts and critical thinking. Sensitivity and specificity help in both data collection and analysis of clinical data. In our history and review of systems, we're also asking highly sensitive and specific questions. Questions with high sensitivity are useful for screening and supporting the clinical diagnosis. For example, have you had pain in your chest is a highly sensitive question for diagnosing angina, but not that specific since there are other causes of chest pain. Another more specific question is needed to confirm, such as, is the pain precipitated by exertion or relieved by rest? That's a more specific question to angina, or MI. Look at the data from your physical assessment. Certain physical findings are sensitive indicators of specific diseases. In other words, for example, the presence of a systolic murmur has a high sensitivity for aortic stenosis, but not specific, since many other conditions produce systolic murmurs. There are many false positives. Using a systolic murmur as your only diagnostic criteria for aortic stenosis would lead to many false positive diagnoses. Combining your data from the history and the physical allows you to test your hypothesis. The absence of symptoms and signs, also diagnostically useful, are called pertinent negatives. It's important to record your pertinent positives and your pertinent negatives, as these help you in determining your final diagnosis. Example, the absence of orthopnea in patients with severe dyspnea makes left ventricular failure less likely. You start to generate your hypotheses with the chief complaint and build the evidence for one hypothesis while discarding another based on your history, review of systems, and your physical exam. When you're developing the history of present illness, a skilled clinician will borrow information from the past medical history, the family history, and the review of systems. They will ask probing questions to determine risk factors for a tentative hypothesis. In both the history and physical exam, search for other manifestations of the symptoms of your tentative diagnosis. By generating these tentative hypotheses early and testing them sequentially throughout your data collection, you improve your efficiency and the relevance and value of data collected. As the saying goes, you collect less ore, but you find more gold. And now, voila, your diagnosis and plan is complete.